Good evening, friends. Welcome you all to USI ISU Smart Learning Program. Today, the topic is fungal urinary tract infection. I request our President, Dr. Alit Shah, to give his opening remarks.
Yeah. Thank you, Dr. Vishwarup. It's a matter of great pleasure and honor to address you as USI President and Smart Learning Program. This particular topic, the fungal infection of urinary tract, is a very uncommon topic because most of the time, most of the people just do not understand ABC of it. I am sure after the end of this program with the experts' opinion, everybody would be learning and would be much better for the management of the fungal infections. Wish you all the best and thank you, ISU USI program. Thank you.
Thank you very much, sir. I request our Honorary Secretary, Dr. Uttam Mete, to give his remarks.
Good evening, everybody. Thank you, Dr. Vishwarup, Mr. President, sir, the faculty today, and all the delegates who have joined online for this seminar today, webinar today. As our President says, I do agree that this is rarely being discussed, though it is being managed day to day. And we are honored to have faculty like Professor Ganesh Gopalakrishnan and others. So he is the teacher of teachers, and I'm sure we're going to learn a lot from him. I know him for so many decades. He was the past president of USI, and other faculty members who are going to teach us today in our School of Urology. Definitely, I know Dr. Vishwarup very well. He has got in-depth knowledge in these areas, and I am sure that in this program, not only it will be you see, it is not possible to discuss everything in 1.5 hours. So, but basically the overview of this thing will be done, and I wish all of us will be engaged in interaction. Or will there be any case discussion? I think there will be a case discussion, isn't it?
Yes.
Okay. So with this,
We
because
have a
I don't
case
waste the valuable time by all this talk, so I wish all the success, and then I think we can start. And welcome, and again, we are honored to have a teacher like Dr. Ganesh Gopalakrishnan, sir. Thank you very much.
Thank you, sir. Sir, we actually started the USI ISU Smart Learning Program with urinary infections, the sepsis and urinary tract infections by Dr. Rishi Nair. And if you look at the fungal urinary tract infections, actually in the current edition of Campbell, there is only off page, and that too on pediatric fungal urinary tract infections. And we see there is a sudden surge of fungal infections, maybe due to in the post-COVID time. I thought it is relevant that we learn from the experts, and to talk and educate us, we have Dr. Lavanya, who is a microbiologist. She's an associate professor in PSG Medical College. She did her MBBS from Lady Harding Medical College and MD from Maulana Azad Medical College, Delhi. Her special interest is mycology. She will tell us about the basics of fungal urinary tract infection. Dr. Lavanya. Please share your slides.
Thank you, sir. Thank you for giving me this opportunity. Let's start with the presentation. Sir, is my screen visible on a slide share mode?
Yes. It is seen.
All right. So good evening, everyone. And today I'll be talking about the fungal infections of the urinary tract. Mainly, I will talk about the epidemiology, etiopathogenesis, and the diagnostic aspects of the fungal infections. So with a brief introduction, let's start this lecture. First, funguria is actually frequent finding in hospitalized patients, mainly in the ICU patients, and almost always it is with Candida species. But the most difficult diagnostic problem which is there with this type of candiduria is whether to determine whether it is infection or it is colonization. And apart from Candida, there are other organisms also like blastomyces or aspergillus, cryptococcus, which mostly reflect that it is a disseminated infection rather than a localized urinary tract infection. What are the causative fungi which which affects the urinary tract? So first of all, it is Candida. Candidiasis is mainly seen with both lower as well as the upper urinary tract infection, and it infects both bladder and kidney. But as we discussed previously, Cryptococcus, blastomyces, histoplasmosis, coccidiomycosis. Though blastomycosis, coccidiomycosis is not seen in India, but still histoplasmosis is seen in the northern part of India. And then aspergillosis, mucormycosis are all seen mainly with they cause infection of the kidney, more like an upper UTI rather than infection of the bladder. That itself shows that it is mostly part of a disseminated infection, or it is either through hematogenous spread. And apart from that, Trichosporin asahi can also cause bladder colonization or infection. So let's start with Candida. Candida, as we all know, it is a common inhabitant of the perineum. So it colonizes the perineal region and like vagina in the females. And what are the risk factors that are associated with the urinary tract infection, mainly caused by the Candida? If we see with lower urinary tract infection, it is mainly the indwelling bladder catheter. The most common is indwelling bladder catheter, which is the predisposing factor for lower urinary tract infections. And older age, female, diabetes, any urinary flow obstruction, and or prior usage of antibiotics, urinary tract instrumentation can all be the predisposing factors for lower candiduria or candiduria. And in case of upper urinary tract infection, the risk factors almost are the same, like older age, diabetes, antibiotics, obstruction, urinary tract instrumentation. And when hematogenous spread is suspected, when the kidney is involved through hematogenous spread, then the risk factors are more like immunocompromised status, like neutropenia or any recent surgery, central venous catheterization, parenteral nutrition, similar to what we see, like these risk factors, which are similar to what causes candidemia, can also cause candiduria. So just to substantiate that, one study I have quoted here, which has seen that a single patient can have multiple risk factors, and the most common risk factor that can lead to candiduria are like urinary drainage devices, that is indwelling urinary catheter, followed by diabetes and urinary tract abnormalities seen in those percentage of cases. Let's go on to the pathogenesis. Like already mentioned, pathogenesis either can be of two routes. One is the hematogenous route, and the other one is the ascending route. And both of them can either lead to upper or lower UTI. Sometimes, rarely, we can also see graft site candidiasis. Basically, that is due to the contamination of donor kidney during the harvesting procedure. So when it is done in an unsterile way, not like grossly unsterile, like if there is a contamination during harvesting, that can also lead to graft site candidiasis. And if we see the candidiasis, the urinary candidiasis or candiduria, the pathogenesis is a two-step process. First, the candida has to attach to the endothelial surface, and second, it has to penetrate the endothelial tissue. And so the invasion is mainly by attachment to the capillary walls via the adherence mechanism, which are due to presence of certain virulence factors which are present, like cell wall proteins in the candidal cell wall, which are ASL protein or hyphal cell wall protein. So these proteins help in attachment to the capillary walls. And next step would be the penetration of this organism into the tissue. So that is mainly by formation of pseudohyphae or hyphal formation, but that is not the only factor. Even other factors, like it produces certain virulence factors like proteinases and serine proteinases, lipases. So all of them lead to or helps the candida to invade the tissue. Again, I want to emphasize this point. Like earlier, it was noticed that pseudohyphal formation was a marker of infection, but these days it is not, because even the organism the candida that doesn't produce pseudohyphae, some certain species like glabrata and all, can still cause infection, though it doesn't produce any pseudohyphae. And then presence of indwelling bladder catheter also increases or predisposes for biofilm formation. So it provides a base material for the candida to multiply and form biofilm, and this biofilm formation is responsible for persistent colonization. Moving on to microbiology of the Candiduria, the main organism is like Candida albicans. Almost 50 to 70% of all Candiduria cases, we isolate Candida albicans. Then next will be next common is glabrata, and then others species like Candida tropicalis, Candida parapsilosis are less common, and other species apart from this like Guillermondi and Cruzi are rarely isolated. But currently, the shift is towards the Candida glabrata and Candida tropicalis. So these are the mains. The non-albican species are the ones which are causing more infection compared to the Candida albicans. And why we need to know this? And this we have to see what is more prevalent in our own geographical location, because only when we know what is common in our location, we can start on fluconazole, which is commonly started as empirical therapy for Candiduria, if at all it is required, because fluconazole resistant, like most of the Candida glabrata, though it may be susceptible in the laboratory in vitro, but it may not work in vivo. So most of the Candida glabrata isolates are resistant to fluconazole, and Candida krusei has intrinsic resistance to fluconazole. So fluconazole will not work against Candida krusei as well. So that is why we need to know which Candida species is prevalent in our geographical location, so that we can start the appropriate empirical therapy. I have put this slide. This is actually from my institute. So this is just 1 year data of all the urine culture we have received. So if we can see here, the total number of culture is around 54,000, 55,000. And out of that, the positive urine culture is around 2,700. And of which, if we see the total number of Candida which has been isolated is around 390. So the percentage of Candida out of all positive urine culture will be around 14.17%. And these are the organisms, the species of Candida which are most commonly isolated in our institute. Like I said, these days the shift is more towards Candida tropicalis and more towards Candida glabrata, mainly in people, in elderly people, in older age people. And so tropicalis, if we see, it is highest, followed by albicans, and then there are other Candida species. Sometimes we may not be able to identify the species level within 3 to 4 days. So we just give the preliminary report as Candida species or Candida non-albicans. And then Candida glabrata, Trichosporon asahi, and Parapsilosis guillermondi krusei are other species which we have isolated from our institute in the urine culture sample. Next, we need to see whether this, whatever Candida we have isolated from the urine sample, is it really an infection or it is just a colonization? Because as we all know, most patients, it is mainly colonization, and almost most of the patients are asymptomatic. So it is very difficult to differentiate between colonization and bladder infection. Infected patients may have symptoms like dysuria frequency and suprapubic discomfort, but most of the infected patients might not have symptoms at all. Then another marker of infection, generally if we see in urine culture for bacteriology, pyuria, we consider it one of the diagnostic marker of some persisting infection. So, but in case of fungal candiduria or candiduria, we cannot consider that because pyuria is common in chronic indwelling bladder catheter, patients with chronic indwelling bladder catheter. And also in some patients who are having candiduria can have concomitant bacterial infection. So in that case, pyuria could be because of the bacterial infection rather than the candiduria. So, but in patients who do not have an indwelling bladder catheter or bacteriuria, the presence of pyuria may slightly tell us that it is probably an infection with candida rather than colonization. And like said earlier, presence of pseudohyphae is not a marker of infection. It is not considered as a marker of infection these days. And also the number of colonies, like significant bacteria, which is seen in with bacterial infection, doesn't play a role in Candida. So even if colonization is there, the colony count may be more than 10 to power 5. And even if there is a real infection, the colony count can be just 10 to power 4 CFU per ml. So it actually does not distinguish colonization from infection. So moving on to diagnosis. Again, the diagnosis is a bit difficult because of the said reasons, like it is difficult to differentiate between contamination or colonization with infection. So whenever we are isolating Candida in the urine sample, we always ask for a repeat sample. So when the next day repeat sample, which is a which is mainly we a request for a midstream clean catch urine sample, and if there is no Candida growing the next day, then no further diagnostic studies are required. But if next day, if midstream urine is not possible, to collect a midstream urine is not possible, like in older females where they might not collect by a proper way or proper asepsis, then we can go with catheterization in and out, where we insert the catheter, collect the urine sample, and remove the catheter. Or in patients who are having indwelling urinary catheter, there the older catheter can be removed and a new catheter can be placed, and a second urine sample can be collected the next day. And if the Candida grows the next day, then therapeutic interventions may be needed depending upon the symptomology of the patient. Generally, ECMM guidelines or ECMID guidelines recommend that if the patient is mildly symptomatic or asymptomatic but is having candiduria, then there is no requirement for any further treatment. So under laboratory diagnosis, like we discussed, we need to collect midstream clean catch urine sample. That is the most preferable sample. If not, in patients with indwelling catheter, we can remove the catheter and do a catheter in and out sampling. And the test which we commonly employ for identification of candiduria is direct microscopy, where we can do a gram staining. Gram staining will only stain the Candida species. If there are other molds like aspergillosis or mucor or histoplasmosis, cryptococcus, then gram staining may not be useful. So in that case, if there is a strong clinical suspicion, the clinician can request for other fungal stains for molds. And culture, again, the routine culture media, what we use, the urochrome agar or the blood agar, which is used for the bacterial urinary tract infection, also supports the growth of Candida. But like if fungal molds are suspected, then clinician needs to request special fungal culture for the urinary the urine sample which has been sent. And in that case, we inoculate it on Sabros dextrose agar and incubate at two temperatures, 37 and 25 for 3 weeks, to identify the molds and dimorphic fungi. So I just wanted to show the picture how it like how do we diagnose in laboratory. We have something called as a chrome agar. Chrome agar, each species of Candida will produce different color on the chrome agar. So this helps us to identify the species at the earliest possible time. So like green color maybe Candida albicans, and blue is Candida tropicalis, and white can be Candida glabrata, and so on. Guillermondi can be purple, and so on. And also this is the gram staining appearance of Candida, where you can see the budding yeast cells as well as the pseudohyphae. And this is the wet mount, where again, which we generally do for urine sample, we can see budding yeast cells. And this is followed by, once the identification is done, it is followed by antifungal susceptibility testing, where generally we use the distribution method for Candida and Vitek 2 AFST for, again, wherever it is available, automation is available, we can use Vitek 2 antifungal susceptibility testing. For molds, generally antifungal susceptibility testing is not done, but it is being done in certain centers, and we can send a sample there if we do require antifungal susceptibility, because generally molds we know which are intrinsically resistant and which are susceptible to which type of antifungal. So routinely it is not performed. But for Candida, yes, we do antifungal susceptibility testing, and this is the by disc diffusion method. And I have attached in Vitek report where we can also get the MIC values like for fluconazole, minimum inhibitory concentration, and depending on that, we can choose the antifungal of choice. Moving on to complications, generally candiduria can lead on to perinephric abscess or fungus ball or prostate abscess. But per se, candidemia or invasive candidiasis following candiduria is hardly seen. And prevention would be removal or replacing indwelling catheter. Removal of the risk factors is one of the way of preventing this candiduria. And if at all indwelling catheter is there, then a bundle care approach can be done for the maintenance of the urinary catheter. Treatment I haven't discussed because it would be discussed by the next speaker, by Dr. Balvinod sir. I have also included for completion sake the fungal peritonitis seen in peritoneal dialysis. So in cases of peritoneal dialysis, again Candida is the species is the one which causes majority of the episodes of peritonitis, but other fungi can also cause peritonitis like Aspergillus and Pityliomyces fusarium, Acrimonium, Mucorales, Trichosporon, Cryptococcus, and dimorphic fungi like Histoplasma and Coccidioides. Fungal infection with peritoneal dialysis, mainly it is bacterial peritonitis, but fungal peritonitis accounts for just 1 to 15% of all peritonitis episodes related to peritoneal dialysis. And clinical features, maybe I can skip a bit. Generally, if it's a fungal peritonitis is suspected, the dialysate will be cloudy and patient will have abdominal pain, fever, and nausea. And almost 10 ml of peritoneal fluid needs to be sent for fungal culture for diagnosis. And especially the clinician has to mention that they are suspecting fungal peritonitis. Then only we will put the sample, inoculate the sample on Sabros dextrose agar and keep it for at least 3 weeks, because most of the molds takes minimum of 1 to 3 weeks to grow. And if there is a strong suspicion that the patient is having fungal peritonitis and fungal cultures are negative, then again the clinician or it can be the clinician can convey to microbiologist, where we may use some enriched culture like lipid infused enriched medium, which will facilitate the growth of malassezia, which is again one of the causes of peritonitis, fungal peritonitis. At this point of time, beta D glucan test, which is more plays a more diagnostic role in candidemia or invasive candidiasis, but for peritonitis, its role is not still well defined. And the last one is in the cases of renal transplantation. So renal transplantation patients have the lowest incidence of invasive fungal infection followed by any solid organ transplantation. So, and it is actually estimated at a rate of 1.3%. And again, candidiasis is the most common invasive fungal infection in solid organ transplant recipient, followed by disseminated cryptococcosis, aspergillosis, or endemic mycosis like histoplasma, or any other unspecified mold infections. So these are my references. I have actually taken most of it from the textbook of medical mycology, and rest are from the articles and certain guidelines. So thank you. And if you have any questions, I'm ready to answer it.
Yeah, just 2 questions which were there.
Yes, sir.
One was, what do you mean by molds, and what is bundle care approach?
Sure, sir. Fungus is basically divided into yeast-like molds and dimorphic fungi. Molds are like Aspergillus and others, Penicillium and Penicillium, Pityliomyces, Fusarium. These are all the genuses which falls under molds, and basically they have something called as mycelium or hyphae. They have only the hyphae. Yeast are the ones are like Candida, which have budding yeast cells as well as pseudo hyphae. So that is something to do with the morphology of the fungus, based on which we divide them into molds and dimorphic fungi and yeast. And the second question, bundle care approach, it is basically when, as we have seen, your indwelling urinary catheter is the most common risk factor for candiduria because of biofilm formation and colonization. So Bundle care approach is nothing but there are certain steps which we need to follow for every patient who is having indwelling catheter, so that asepsis is maintained and the patient is not going to develop any catheter related infection. So we have insertion bundle and as well as maintenance bundle. Insertion bundle is a 1 point checklist. So while inserting, you have to follow aseptic precautions. But maintenance bundle has more parameters, like every day we need to give the perianal care, vaginal or meatal care in the patients, and do a hand hygiene whenever we are handling the urinary catheter, and also assess whether we can remove the catheter if it is not required. And one more is like emptying of the bags and placing the urinary catheter on the anterior aspect of the thigh. All these steps will minimize the patient developing infection. So that is called as bundle care approach.
Thank you, Dr. Lavanya.
Thank you so much, sir.
I request Dr. Balavinod to speak on management of fungal infections of the urinary tract. He is an infectious disease consultant in Kupaswamy Naidu Memorial Hospital, Coimbatore. His special areas of interest are critical care infections, transplant-related infections, and he is very much part of the hospital infection control in his hospital. Dr. Balavinod.
Good evening, sir. Good evening, everyone. It's a great pleasure to be here, and thanks for the opportunity, Urology Society of India, for this giving me this opportunity to present this topic. And I think my slides are visible, is it?
Yeah, you can put into a full slide presentation.
I've already put it into a full mode. I mean, like, I hope it's visible.
The slides are visible. If you can put it into a play mode.
Is it fine, sir? Is it kind
Yeah,
of
it's
visible?
okay. Yes.
Put on PowerPoint
Okay.
project.
So, I didn't get you, sir.
You can put on a PowerPoint projection so the whole screen gets it. Right now, it looks like just the single slides. That's what.
I mean,
In the bottom, you can see the slide presentation.
You see the third one, which has got like a computer sitting on it, at the bottom next to the 87%, the one, the icon just next to that.
Slideshow mode, yeah.
yes, sir. I've already put it as a slide. Yeah.
Oh, okay.
Yeah.
Okay, carry on.
Okay, sir.
Go ahead.
Yes. Yes. So once again, thanks. And I've having listened to Dr. Lavanya's extensive talk about the microbiology of fungal infections, and she has almost covered a part of what I have to talk. So there is a lot of overlap. It will be a little bit reinforcement, and I'll skip through few things, and I'll reinforce few things which she has already talked about. So coming to fungal infections, we know that Candiduria or funguria, to specifically mention, Candiduria is very common in hospitalized patients, and most of the times it's benign. And invasive infections of the kidney is very unusual, but it is very difficult to treat. Though the scenario is rare, it is going to be very difficult to treat. Vast majority of the fungal infections are of the kidney and bladder are due to Candida species, as already mentioned by Dr. Lavanya. So the other infections are also there, as well as mucor, etc., dimorphic fungi and all, which Dr. Lavanya has already spoken about. My talk here, what I will cover is basically mostly Candida, a little bit of Aspergillus and mucor if time permits. So coming to the key mechanisms of Candida infections of bladder and kidney, there are two mechanisms. Dr. Lavanya has already told about it. Whenever there is a device in situ in the bladder, it forms a biofilm which leads to colonization of the Candida species which is there in the perineum, and which gets into the bladder, from bladder into the upper system through the vesico-ureteral reflex. And there can be hematogenous dissemination due to a candidemia into kidney, which is not much of a worry. We are not worried in terms of urinary tract infection, and most of the times we treat the candidemia, which takes care of the kidney as well. Very rarely we have renal manifestation of a bloodstream seeding of the kidney, which we have to address. Most of the times it is covered by the systemic therapy, and the symptoms are all mostly systemic. So coming to the epidemiology, it is a very common even candiduria per se. Again, the problem of colonization and infection arises. You can see that the Candida is the third most common organism which is isolated from the urine in hospitalized patients. This is a age-old data from a European study published in 2001.
Yeah, your slides are not moving. Sorry to interrupt. The slides are not moving.
For me, it's kind of okay.
I think you have to exit and share the slide once again. Yeah. Now we can see.
Is it okay now?
Yeah, sure. Go ahead.
Is it moving, sir?
Yeah,
Is the
go
slide
ahead.
visible, sir?
Yes.
Yes. This is a study shown by Dr. Lavanya where the common risk factors for candiduria has been mentioned. The most common factor is the presence of a device in the urinary tract, and prior antibiotic therapy, and risk factors like diabetes, urinary tract pathology, and malignancy. And in 11%, there is no risk factor at all. Just candiduria can be there. And always there is a problem. Dr. Lavanya has already covered this. You have urinary isolate of Candida. Whether it is true infection or colonization is very difficult to differentiate, because pyuria is very common in bladder catheters, and just because there is a growth, we cannot take it as an infection, though there is no definite cutoff of growth with regards to Candida. We'll have to correlate with the symptoms, and there should not be any alternative explanation for the patient's symptoms. Then only we can take it into consideration. So coming to in some patients, what can happen is this persistent candiduria can produce ascending infection, which especially with in the setting of urinary tract abnormality like obstruction can form a fungal ball. And very rarely the candidemia patients can see the kidney and then form a papillary necrosis, and which can lead to fungal balls, which can lead to obstruction. But most of the times, candiduria due to disseminated candidiasis is benign, and taking care of the systemic candidemia itself will settle the kidney as well. So coming to each and every part of Candida UTI, when we see cystitis, the common symptoms are as usual dysuria, frequency, and suprapubic discomfort. And coming to ascending infection, usually it is a subacute to chronic course. It involves the renal pelvis and medulla, and the cortex is paired, and common in diabetics, especially those who have got the atonic bladder, neurogenic bladder, and glycosuria with anatomical abnormalities. Kidney is the most common involved in a diabetic UTI. In ascending UTI, and it's most commonly unilateral. Complications like fungal balls and perinephric abscess can occur, and rarely emphysematous pyelonephritis due to Candida also can occur. And if you look at the predisposing factors for ascending infection, most of the times there should be some abnormality in the tract, like a stone there, or a recent manipulation with for a lithotripsy or a ureteroscopy, presence of nephrostomy tubes, prostatic hypertrophy, neurogenic bladder, penile prosthesis, and chronic bladder catheterization. To make it simple, presence of any foreign body always brews fungus, especially Candida, in the urinary tract system. And most of these patients with ascending infections can have flank pain, which can be there for weeks together, or sometimes costovertebral angle tenderness also can be there. Systemic symptoms like fever or other signs of systemic signs like fatigue, weight loss, etc., may or may not be present in these patients. And if you look at the candidemia causing renal seeding, most of the times you are masked with the systemic symptoms. The patient would be sick with a shock, septicemia, etc. And kidney is very commonly seeded due to candidemia, and very rarely you can get symptoms pertaining to the kidney like a flank pain, costovertebral angle tenderness, etc. But most of the times it's all systemic symptoms which will mask the specific symptoms of the kidney. Rarely candidemia, as I previously mentioned, can cause papillary necrosis, and slough papillae can be a nidus for fungal ball formation. And candida infective endocarditis sometimes can produce vascular occlusion of the kidney and can cause renal infarcts as well. This is a classical picture of microabscesses due to candidemia, not due to ascending
Dr. Bala,
UTI, but due to a bloodstream
Dr.
infection
Bala,
seeding the kidney. Yes, sir.
Dr. Bala, the slides are not moving. We are not seeing that images which you want to show.
I'll just come out and
Yeah,
comment,
I
sir.
think
That
that's
will be
better.
better,
Yeah,
I think.
yeah.
Can central office
I
do
have a
something
good
for this?
connection, but somehow something is happening.
Like, can central office do Kiran ji? Kiran and Navneet?
Yes, sir. We can just share
Can
it now, sir.
it was not moving at all. It was not in the slideshow mode.
Even without slideshow mode, it should move, but it was not moving.
Actually, I'm showing it through the slideshow mode, sir, but like then.
It is not coming here.
Is it visible, sir?
Your slides are not seen now. Just share the slides.
Already shared, sir. I mean, 1 month. Is it visible, sir?
Yeah, no, yeah, it's started coming now. Proceed, please.
Is it visible, sir?
Yeah.
But not in slideshow mode.
Actually, I put it in slideshow mode, sir. It's visible as slideshow.
Just click up and down at least if the slides are.
Yes, you can
All
continue.
right, even if it is moving, that's fine, right? No problem.
Yeah, just check once up and down, and then we can proceed.
Yeah. Is that fine, sir? Are you able
No,
to
just
visualize?
slides are not
check for
moving.
the movement. Movement check karo.
I'm moving the slides, sir. I'm moving the slides.
It is not moving again.
Am I audible at least, sir?
You are audible. Your slide, only one slide is seen with that the kidney image. The slides are not moving.
Bala, the icon is there's a yellow light and in the slideshow mode. I mean, yes, click on that now. Click on that last one.
Actually, it's like I'll put it in the slideshow mode, sir. It's scrolling up for me. Actually, it's but somehow it's not reaching through the presentation. I'm not sure why. Actually,
carry
and
on.
my internet connection seems to be stable. Can I share it with the central organizer so that he can scroll it for me and I can present, sir? Is that fine?
Yeah, I think. Navneet, can you just help him to do that?
Yes, sir. Please share it to the office ID, sir.
Can you just, I mean,
Yes,
like,
now it's moving.
Yeah, now it is moving.
I'll text it here,
I'll
sir.
just share my slide. Yes, sir.
Sir, you can there are two, if you share screen, there will be two slides you can see. You click on the full page slide and then you'll be able to work it out.
So if you could give me your email ID, I'll just share my
Yes, sir.
slides with you so that you
Putting
can
it-
scroll it for me if it is not visible.
No problem, sir. I'm just putting it in the chat.
Should I mail you, sir? I mean, like, if you put it in the chat, I'll.
Yes.
So I've sent it to you actually. If you could.
I'm waiting to receive it, sir.
Yeah.
Yeah, got it, sir.
Yes, sir. Well, I've stopped sharing, sir. If you could share it, I can just present it. That'll be better. I'll say next. You can scroll it for me. Sorry.
Definitely, sir. Just a moment.
Yeah. I think it'll be. You can scroll through a bit. Still more. Still more. Still more.
Yeah.
Still more. Little before, sorry. Little before. Little before. 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 Before.
Yeah.
Little before. Little before. Little before. Still more before. Yeah. Yeah. Here. Yes, sir. Yes. So as I already mentioned, can everyone hear me? Sorry.
Yeah, sure.
Yes, sir.
Please go ahead.
Yes. So the previous slides. Little after, if you could come to that picture mode. Next.
Yeah, this one.
Yeah. So as I already told, cystitis, the usual symptoms are there. Next. So ascending infection, I've already mentioned. Next. 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 So with regards to renal transplantation also, the risk factors for candiduria are similar. Even if there is candiduria in renal transplant, only 5% develop candidemia despite having immunosuppression. So we need not treat all patients with renal transplant who have candida in urine, actually. So treating all of them never had a survival benefit. Exception is somebody who has got a asymptomatic candiduria early after transplantation, when there is stents in place, there is high risk for fungal balls and allograft pyelonephritis. This is the only situation you will have to treat with regards to renal transplantation. Next. So to diagnose candidiuria, as you all know, as Dr. Lavanya previously mentioned, whenever you get candida in urine, it can be due to a contamination from the perineal flora, or it could be a chronic colonization of the bladder from the catheter, or it could be a local infection of the bladder, which is otherwise called as cystitis, or it could be pyelonephritis, the infection of the kidney parenchyma. Next. So this is a classical picture which Dr. Lavanya explained. Next, pseudohyphae, branching pseudohyphae. Next, and this is a agar plate showing a curdy white colonies showing Candida. Next. So when to evaluate and treat them, because you'll have to be able to differentiate this colonization from infection. Whenever a patient has urinary tract symptoms with no other alternative explanation, somebody who has a sepsis syndrome, all other causes have been excluded, and you have a urinary tract growth, repeated urinary tract growth, and there is no other explanation, and patient is symptomatic, then you have to evaluate. Even in patients who are asymptomatic, who has got persistent candidiuria, right, left, and center, all the repeated cultures are positive for Candida, especially if they are diabetics, if they have urological abnormalities which can lead to silent formation of fungal balls, and in neonates where the system is very fragile and stable, even a simple candidiuria, asymptomatic candidiuria can be a harbinger of invasive infection. These are the situations where you have to evaluate candidiuria. Otherwise, you need not evaluate candidiuria at all. Next. So how do you evaluate? The imaging modalities are either ultrasound or a CT. Contrast enhanced CT is preferable whenever possible. What it will show is hydronephrosis due to obstruction of in the downstream, or fungal balls due to a chronic Candida infections of the kidney, and there can be complications like perinephric abscesses associated with ascending infections. When do you do blood cultures? Whenever a patient has got urinary tract symptoms, but at the same time is systemically sick, like having high grade fever with chills, with a shock and all, then we have to do good amount of high volume blood cultures as well. Next. So this is an imaging finding where you can see in the ultrasound there is a bladder fungal ball. Next. And this is a CT IV pyelogram where it shows filling defects in the renal pelvis, which is again a fungal ball. Next. These all should make a suspect of a fungal ball in a patient with fever with urinary tract symptom. We'll have to think of with this kind of imaging finding, we'll have to think of a fungal ball and evaluate accordingly. And this is another patient with a CT which is seeded with Candida due to presence of systemic candidemia. This has happened in a neutropenic, where we can visualize renal microabscesses, which is taken care by the systemic treatment per se, rather than a typical urological intervention. Here we don't need any intervention at all. Systemic treatment would take care of these renal abscesses which have seeded the kidney, especially in a neutropenic patient. Next. So coming to treatment, asymptomatic candidiuria, most often 99% will not need treatment except for these few scenarios, especially in a neutropenic or a very low birth weight infant less than 1.5 gram, where presence of urine candida has to be considered as disseminated infection and should be treated. And if you are going to do a urinary tract manipulation, for example, you have a asymptomatic candidiuria, but you are going to do a cystoscopy, invasive cystoscopy, stenting, etc. Or if you are going to manipulate the mucosa, then you will have to treat accordingly as per the culture. If it is the azole sensitive candida, we should treat with fluconazole fluconazole 400 mg, or if it is azole resistant candida, we'll have to treat with amphotericin conventional 0.3 to 0.6 mg a few days before and after a procedure. We'll have to treat like a proper UTI, though it is asymptomatic, especially because the interventions can lead to a systemic sepsis. Next. So in renal transplantation, as I already told, just because there is a candida in the urine, we need not treat at all. We'll have to decide case by case. Only when the in the early transplant, post-transplant period, when ureteral stents are in place, where there is a high risk of graft infection, we'll have to treat. Next. More than treating, what is very important is removal of the risk factors, especially the foreign bodies. Whatever is there should come out, whether a bladder catheter or any other tubes inside, or a stent which is unnecessary, which has to be taken out. More than that, unnecessary antibiotics has to be discontinued, because antibiotics predispose to more and more candida in the body. So whenever the stent or a foreign body removal is not possible, at least replacement should be done. Next. So symptomatic candidiuria should always be treated. For example, a patient has a azole sensitive candida. The drug of choice is fluconazole. Fluconazole is a time-tested drug. It has got very good urine levels. It has got good MICs in the urine. It is a good drug of choice. But for fluconazole-resistant candida infection, the problem arises because whatever we have is amphotericin, which has got a reasonable amount of urine levels actually. On this, in this also, we should remember that liposomal ampho never has good urine level. So though it's a renal safe drug, it is not a good drug of choice for a collecting system infection in the urinary tract, because it will never get into the collecting system. So conventional amphotericin B is a drug of choice for fluconazole resistant collecting system infection involving the renal pelvis, ureter, or the bladder. And for systemic candidemia, follow the recommendations of candidemia, especially echinocandins or the drug of choice, which will act well at the renal parenchyma, but again will not get into the urine. Next. So, like as I already mentioned, lipid formulation will never get into the urinary collecting system. So these are not the drug of choice. Next. So coming to cystitis, if it is an azole sensitive stain, that is fluconazole sensitive stain, the treatment of choice is fluconazole 200 mg for 2 weeks. If it is going to be a fluconazole resistant stain, then especially like glabrata, as Dr. Lavanya mentioned, the drug of choice is again amphotericin B. It's a little lower dose compared to systemic sepsis due to candida. 0.3 to 0.6 mg per kg is what we use up to 7 days. There is a role for flucytosine as well. When we use it, it is given for 7 to 10 days. But this is not the generally flucytosine monotherapy is contraindicated because it will lead to resistance. So the preferable choice in this situation would be amphotericin monotherapy. If it is due to Candida krusei, which is again flucytosine as well as fluconazole resistant, the drug of choice is amphotericin alone. And there is a alternative treatment which is again mentioned, not the recommended treatment. Alternative treatment is amphotericin B bladder irrigation with 50 mg per liter sterile with sterile water irrigation can be done for 5 days, especially with fluconazole resistant organism. But this is not at all the regimen of choice. First choice is always fluconazole in azole sensitive stains, and amphotericin or flucytosine in azole resistant stains. And always indwelling bladder catheters whenever possible should be removed. Coming to pyelonephritis, again the treatment is fluconazole if it is sensitive. The dose is little higher, 400 mg for 2 weeks. But if it is going to be a fluconazole resistant candida like glabrata, The drug of choice is again amphotericin B, which is given for 7 days minimum, but it can be combined given because it's a pyelonephritis, it's a parenchymal infection. We can combine amphotericin with flucytosine, which can be given both together given for 7 days. But if you use flucytosine as a single agent, you should use it for 2 weeks in case of pyelonephritis. Again, for cruzi, which is a azole resistant candida, we'll have to treat with amphotericin for 7 days. The most important point is any foreign body or obstruction should be removed. For example, a stent should be removed or replaced, a nephrostomy tube should be removed or replaced, and the stone should come out. These are the dictum. Coming to fungal balls, surgical removal is strongly recommended along with the systemic therapy. So antifungal therapy should be given according to pyelonephritis recommendations, but always, most of the times, you need surgical removal, either a less invasive endourological intervention or if it is a complicated loculated infection, we'll have to open and treat. So there is a role for adjunct therapy with irrigation of amphotericin B into the nephrostomy tube along with the systemic therapy in this case, where we use the 50 mg amphotericin and 500 ml sterile water, which is given as an adjunct along with the systemic therapy in case of urinary fungal balls, where the primary treatment is surgery along with systemic therapy, and irrigation might have a role as an adjunct therapy. Sorry. Next. So, as I already told, irrigation is always either an alternative recommendation in cystitis or an adjunct therapy in case of fungal balls. It is never a primary therapy of choice in any of these situations, because the bladder irrigation with the ampho would clear the fungus, but the effect is very transient. So it is, we should remember, it is not the primary form of therapy. It is always as an alternative or adjunct. Next. So flucytosine, it's a commonly used drug for urinary tract infections due to Candida, but the problem is it's a very good drug, achieves very good level in urine. It is a Candida specific agent. It will not cover other molds like Aspergillus and all. In a patient with renal insufficiency where we are not able to use amphotericin B, we can choose flucytosine. Monotherapy can be tried in a stable patient, but the problem is it comes with the cost of resistance. Most of the times we combine with amphotericin B to prevent the development of resistance. And in Candida cruzi, again, fluconazole or flucytosine both will not work. Amphotericin B is the drug of choice. Next. So looking at the problem with this antifungals is that you can see that, as I already mentioned, apart from fluconazole or flucytosine, none of the other agents have a good urinary penetration at all. Fluconazole and flucytosine have 90% penetration. Even the conventional ampho has only 20% penetration into the collecting system. And liposomal ampho never gets into the collecting system. It is less than 5%. So we should choose agents accordingly. All this voriconazole, posaconazole, all these newer azoles, echinocandins don't penetrate into the collecting system at all. Next. So complications, as I already mentioned, perinephric abscess and fungal formation, ball formation. Very rarely in a post-transplant patient, sometimes renal arteritis with aneurysm formation can occur immediate post-transplant. Next. In case of perinephric abscess, usually drainage is preferred through percutaneous catheters. Large bore catheters with irrigation to remove the thick tenacious secretion is needed. And along with that, if the patient has multiple laculations, we'll have to open up and drain the abscess. And systemic antifungal therapy is must in every case of perinephric abscess, along with the surgical or drainage measures. Next. With regards to fungal ball, always we prefer a surgical as well as medical therapy. None of the single treatment works. Next. Generally, we follow a sequential approach in next. Generally, we follow a sequential approach. We start the systemic therapy because before we handle the urinary tract system with our surgical procedures, it can cause a hematogenous dissemination. So that always start with the systemic therapy recommended for pyelonephritis, then do access the upper tract with either a nephrostomy tube or the collecting system through the retrograde catheters pass through the ureter, then do continue the systemic therapy, then start your irrigation of amphotericin B, which is an adjunct therapy. Then you can debulk the fungal ball through the percutaneous approach per se, along with the lavage. And if at all debulking is not successful, then you'll have to do a surgical approach. After debulking, you'll have to continue the irrigation till the urine cultures are negative and the radiological disease also disappears. Till then, we'll have to continue this irrigation, and at the same time, systemic therapy also should continue, and all other surgical measures like stricture dilatation and, if necessary, open pylotomy has to be done. Next. So till when we have to continue systemic therapy in a case of fungal ball? Most of the times, till you proceed with your surgery, surgical approach or an endoscopic approach where the fungal ball removal is totally accomplished and the symptoms have resolved and urine culture is negative, till then the systemic therapy is continued. There is no defined duration like a simple pyelonephritis there, like 2 weeks. Here it would be 3 to 4 weeks as well, depending upon the patient's response. Next. So very rarely Canada can see the prostate, especially in an old diabetic with typical symptoms like pelvic discomfort and urinary retention, where a transurethral ultrasound or a CT can pick up the abscess. Most of the times it is drained by an interventional radiologist. Fluconazole is a preferable drug if it is a sensitive strain, but in resistant organisms, amphotericin B is a drug of choice. But even echinocandins, the caspofungin, etc., can be tried because it is in an inflamed prostate. It can this systemic drugs can reach the parenchyma. So this way, even echinocandins can work for prostatic abscess. But the conventional drugs are fluconazole or amphotericin B. At least 4 weeks after drainage we'll have to treat. If it is a loculated collection, we'll have to extend the duration of the antifungal. If there is failure to respond, then transurethral resection of prostate should be considered. Next.
Bala.
I think
I'll
stop here.
I think you can stop here. I request Dr.
Yes,
Ganesh to please summarize with for the want of time. Just to the silent features, and then I just give the take-home message. Sir.
Good evening, everybody, and thank you very much. There is no doubt about can you hear me?
Yes, sir.
There is no doubt that all of us in our practice today are seeing more and more of these fungal infections. Many of them are just colonization, but some of them are actually infections. And I think the blame has to come to both the doctor as well as to the patient. Doctor mainly because of the rampant misuse of or rampant use of stents, catheters, antibiotics, and the patient because he's not able to control his diabetes. He's probably immunocompromised for various other reasons. And therefore, we are seeing this whole gamut of patients with severe cystitis primarily, severe cystitis, to the point that they have actually become contracted bladders with severe pain. And this is very worrying because on the one hand, we have learned that these patients don't require treatment because they're just on catheters, they get colonized. But some of them we are seeing who are uncontrolled diabetics in our practice with contracted bladders, and we've actually had to do cystectomy for them simply because of the severe pain and the failure to get managed with the conventional treatments, including bladder irrigation, including anything that is available at our site. So this is a real problem for us. And I think the message that has come very clear from both Lavanya as well as Bala Vinod is that, number one, take out stents, take out catheters, take out foreign bodies which are in the urinary tract, as long as when they are no longer in use. A stent is not a panacea for an operation which is done badly. If there's an obstruction to the lower urinary, if there's an obstruction to the urinary tract, fix that obstruction and take out these foreign bodies. Don't keep reinserting stents again and again because it's not going to help these patients, they get colonized. The second thing is make sure that you don't misuse antibiotics. Your antibiotic stewardship should be so pakka that whatever you do, only so many days in your hospital, that's it, that's the protocol. Don't just rampant misuse any antibiotic just because on whims and fancies or something else. We are seriously seeing a lot of these problems in our hospital. And I think we need to be very concerned about our patients who do not care about controlling their diabetes, do not care about, I think quite a bit of the fault is also theirs. They are not savvy about their control. They are not savvy about their diet. They are not savvy about their exercise. They don't realize the problems that they are suffering because of it. And what we have found in our practice is that the moment they come with the cystitis, we are not talking of pyelonephritis, I'm talking of cystitis, which is 95% of the time, that's what it is. A severe cystitis is their hemoglobin A1C is up the creek. Their blood sugar on that day may be fine, but the hemoglobin A1C is very high. And people don't realize that. I'm very surprised that many physicians who treat actually diabetics do not actually do a hemoglobin A1C on them. I am very disappointed and very surprised that some physicians don't actually do it. And we find that the hemoglobin up is, sometimes we see it at 9.5, 10. And this is very, very disturbing when we actually see these patients with severe cystitis. So I think the bottom line here is, again, to emphasize, take out tubes, take out catheters, change catheters, don't treat asymptomatic infection, treat symptomatic infection with the appropriate antifungals if it requires treatment. Candidemia, fungal infection with septicemia, with candidemia is rare. It's colonization which is more important. I have seen in my practice aspergillosis. I have seen in my practice fungal infections affecting the renal artery in transplant and blowing it out, but these are few and rare between. What is more common is fungal infections in the bladder. Most of them are colonizations. Take the catheter out, change it if you require a catheter, and don't actually treat these patients. They're just producing more and more resistance. I think the one issue that we have not covered today is resistance to these fungal infections. And I think in very short period of time, we're going to see the standard and antifungal agents that we are using becoming resistant simply because, again, we don't know how to treat these patients. We're just banging them right, left, and center just because we think that they need the treatment. I think we need to be very careful about our antifungal stewardship in these cases. Just like we have antibiotic stewardship, we need antifungal stewardship at this point. And I request both Lavanya as well as Bala Vinod to sort of collaborate and produce a sort of blueprint and say this is what is the antifungal stewardship and pass it on to the USI. If there's anything else, then I'm willing to share it, Bobby. But thank you very much. I know time is running out.
Thank you very much, sir. I think you nicely summarized all the points. And in case there are no further things,
Can I,
because of
Dr.
want
Bobby,
of time.
Dr.
Yes,
Bobby,
sir.
can I
Sure,
pass
sir.
some comments for 2 minutes or so?
Sure, sir. Sure.
If you allow me. Very nicely discussed, but what we see the spectrum of fungal infection in urinary tract in PJ is totally different. We have seen a mucormycosis. It's a very, very dangerous angioinvasive infection. And here, urologist as a surgeon has got a major role to play. And the way to diagnosis is early is to take a renal biopsy and you see the mucor and you have to go for a nephrectomy. And because it's an angioinvasive infection, the kidney is totally avascular. And not only that, it spreads to the surrounding colon. So we have to do hardly any patients. I think 1 or 2 patients have survived. And these patients are young patients. They are not immunocompromised patients. So the role of urologist for a fungal infection as a surgeon, the major role is there. And second is what Sir was telling, aspergillus ball. I have also done a percutaneous removal of the aspergillus ball. The only problem is how long to treat them. The aspergillus patients, you have removed it, and what should the drug of choice and how long to treat them. And I have one question for these both of them. Say, for example, a patient who is waiting for renal transplantation and is more or less asymptomatic, but you have found that candiduria is there. And you say that it's very difficult to differentiate colonization versus this infection. So persistent candidiuria without any finding, any patient may be diabetic and is waiting for renal transplantation. Is there any different approach? Do we really need to treat?
Sir, I mean, there is no role for treatment per se, but if he's going to go for a transplant in the in few days, and whenever there is a recurrent candiduria, more than treating, we need to evaluate. That's what the guidelines say. I mean, if the patient has, we don't find any risk factors, but the patient keeps having candiduria, especially diabetic, always do a basic ultrasound or to look for any obstruction or
Everything has been
silent,
done.
because
Everything
most of these patients.
So everything has been done. Definitely, as the urologist, we have ruled out everything, but there is
Yes,
persistence
sir.
of
Yes, sir. Yes, sir. Then if we are proceeding with the transplant, we'll have to treat like a UTA and then proceed with the transplant. So that's what the guidelines say, because transplant is going to have a manipulation of the system where there is a risk of graft infection, and there can be candidemia as well. So in this case, even if he is
I think
asymptomatic,
one of
if
the
we are
things
going
which
to
I can suggest is that this patient should have a selective, like how we have a persistent bacteriuria, we evaluate the patient with selective renal catheterization, get the sample, find out where the source is. Don't just think that it is coming from the bladder, because this patient is putting out small amount of urine from either kidneys. So we need to get the source, and that evaluation, if it is negative, and then probably you can go ahead with doing the transplant with antifungal coverage and avoid stents at that
I would
point
have
of
one
time.
more suggestion, Dr. Vishwarup, on the question that Dr. Uttam said, that if this patient has got persistent candiduria, which is likely to come from the bladder, if you can avoid putting a stent, that'd be better, because then it will colonize and you'll get graft pyelonephritis, which is going to be a major problem in these patients. So if it's a living donor transplant, or even sometimes sometimes in deceased donor, we do have to put a stent because you don't know the output. But if it's a living donor transplant, avoid putting in any foreign body.
Thank you, sir. Sir, what is your experience about mucormycosis? Because we are seeing every
You
now
did
and
touch about mucor, but we
Mhm.
have seen, I'm very surprised you said that the mucor, you didn't see it in that patient who was immunocompromised. I know you are in Chandigarh, but have you looked at patients who have been drugs? You know, these drug addicts, they self-inject themselves. We have seen it, and this is something that we need to be concerned about. So I think we need to look at that, especially they're not immunocompromised, you know, but this is another problem. So, you know, apart from MRSA and fungal infections, we find that some young men have had these because they are injecting themselves, unsterile technique, and they get these infections. So I think we need to be aware of that situation also when you have mucormycosis, which is absolutely life-threatening.
Yes.
I've lost patients with mucor in the kidney. I've lost patients with aspergillus, all transplant. And these were in the days when we were using 240 milligrams of prednisolone for our transplant patients. Huge amount. So we used to see all of them, including nocardia, everything. You know, in those days, I'm talking of the 70s when we started off. Now all that is gone, but we still see the occasional allograft rupture. We've seen allograft arterial aneurysm rupture. Those things happen infrequently. And this is all actually not, we have missed the fungus somewhere. And the immunocompromised state has produced this fungus, but it's been circulating somewhere in this guy and we missed it. That's all.
Thank you, sir. Thank you.
Thank you very much, sir. I thank all the speakers, and especially Dr. Ganesh and Dr. Uttam for chipping in and for the nice case discussion. Thank you. We will conclude the session now.
Good night.
Thank you very much.
Good night. Good night.
Thank you, sir.
Thank you.